Welcome to Distance is No Obstacle, the medical education podcast aimed at providing bite-sized education and information for people working in rural and remote Australia. Today we hear from exercise physiologist Stewart and senior physiotherapist Professor Edgar with their latest findings from their research into long COVID. This is the first of a two-part series.
Good to see you again, Katie. We talked previously, probably must have been about April, May of 2022. We spoke a bit about...
And I don't think that was even in person. So I think today is the actual first time we've met.
Nice to see you, nice to meet you. Now, we spoke a bit about what were our experiences at that time and around that time, sort of coming out of the pandemic. I'm interested to know more about how did you get into this space?
I think we both, in sharing those stories, had really interesting reasons, and that's what puts COVID, it just goes with the flow of the anomaly that is COVID and long COVID, that it's drawn us into different spaces. And for me as an exercise physiologist in community-based care for chronic disease, we won the Global Value-Based Healthcare Prize, so we've been sitting and driving in that value-based healthcare space. I'm particularly inclusive as an allied health, which, is not always great politics, but it is very much reflective of value-based healthcare, and it's a really strong point of difference for us. And I think that the whole long COVID set of symptoms, we became just the go-to people because we had that breadth of allied management capacity, and we'd had the considerations for testing and doing prims and proms because it was a watch and monitor, measure, respond. And I think that's how we evolved into the long COVID space. We've also had great advisory board and medical support that were highly informed in that space. I think it all just, the urgency of COVID leads to that space. But yours is even more interesting.
Well, I don't know whether it's more interesting, but I guess it's really interesting for me to think that, we've somehow met in the middle here in our discussions, because I come from a very acute-based tertiary hospital research-based activity, and specifically in burn injury. And my interest as a physiotherapist was looking at using exercise to prevent the loss of muscle, in particular, in burn patients. And I guess that's where I started really getting interested in the impact of inflammation, the inflammatory response, the immune response associated with the challenges that our body has to deal with in a burn injury, and then the waves of infection that come after a burn injury, because our skin's our primary barrier to infection, and obviously once you've got a hole in your skin, then infection gets in, as the story goes. And with that, we have seen and started to look specifically at the phenomic profiling, the inflammatory profiling, the lipidomics, all these fancy assessments of how a body responds to infection, and prior to that, an inflammatory challenge like a burn. And that has been fascinating for me as a physio, because it's led us down various different roads where we're seeing that, we're now trying to look at what prescription of strength training.
You're getting down to dosage.
Looking for prescription and dosage, and trying to also marry that with the physiological responses, so that we can prevent muscle mass loss, because in a burn situation, your body goes looking for protein, and your most accessible protein store is your muscles. Yeah. And if you're not careful and you don't signal to the body otherwise, then the evolutionary pressure is that you need to heal your skin first. So your first priority is to heal your skin to stop infection getting in.
Yes, and you're drawing all that muscle.
And you don't need your muscle necessarily until you've healed your skin. Whereas we know that if we leave people to heal their skin, let them lie in bed, so they actually have the accelerator of bed rest, and we allow them to heal their skin first and sacrifice their muscle, then their long-term function is potentially irreparably damaged.
Yeah.
And so they may never recover, or they certainly recover to a far lower level than what we see with our burns patients, where we actually get them exercising it straight away. Even if they're in ICU, we get them in the gym.
And I think that, for our worlds would never have met, in a traditional siloed medical environment. You would have continued doing your great work in your space. We would have continued in the community collecting the real world evidence. But that's one thing we have to be grateful for from being COVID putting us in this position, that it has broken down a lot of barriers and it's brought a lot of good research together to be able to look at those value-based propositions and solutions around how do we lean into burns research to pull from cancer and oncology research, and how do we cross-correlate and cross-pollinate all the great research in both those different areas to be able to look at this overarching priority of lean muscle mass preservation. So interestingly, from definition, and we've got a paper accepted, open access long COVID, a BMJ piece of work here that states long COVID is by definition a clinical sequelae 1 year after mild COVID and its association with the SARS-CoV variants. So the difference that we had before was it was 4 months, and again that's interesting with chronic disease correlations as well, that if the symptoms were persistent for 4 months or more, it wasn't. We went through that in our initial presentation, what was the protocol or process for whether it was, because back then in 2022 in April it was about, a diagnostic process and trying to work out what was the issue in hand and therefore what are the timelines. So I think we had it, for 6 weeks, and now it's at 4 weeks. So that's that's an interesting little change.
I think the other major difference is they realise that there's no such thing as a symptom-based diagnosis of long COVID. If you've got 200 symptoms that are attributable to long COVID, then how do you make a diagnosis out of that?
Yeah.
Because you can't really use that as your diagnostic criteria.
Hence that transition into long COVID, where they initially into a post-viral syndrome, post-COVID syndrome.
Yeah.
So there was that shift in that clinical approach, wasn't it? More about the responding of acute and long hospital bed stays and the impact of that.
Yeah.
And severe viral infection.
No, I think that's certainly what's evolved since we last spoke, really.
Yeah.
And I guess one of the things that we should point out to the listeners is that really they shouldn't necessarily have it in their mind that long COVID is one specific thing. So if they have ongoing symptoms, it may or may not be associated with COVID, but they should consider going and actually having some investigations, at least a conversation with their trusted primary practitioner, and get to the bottom of it. At least don't suffer in silence. Make sure that they actually go and take their concerns, and they can be mental health concerns or they can be physical concerns. Go and take that to someone, because it's very likely that some of those symptoms are attributable to a cause.
And you don't know until you watch, measure and monitor.
Correct.
Yeah. I'll just record.
At the moment, I guess the challenge for treating long COVID is that we really just don't know how to diagnose it, other than to identify symptoms and then propose and proceed with investigations that are aiming to identify specific physiological problems that we can actually deal with in different organ systems. So that's sort of the treatment approach, but really we don't have any way of truly diagnosing long COVID. And that is one of the things that I guess the guys from the ANPC are chasing. They're trying to find out what is the phenomic profile of someone who's recovering from COVID, and where along their recovery process do they slide into a long COVID diagnosis. Maybe it's a timing thing, but certainly they've identified a certain profile of the response to COVID. Now what I believe they're looking for is to try and understand when does that drop back down to normal, and when have you recovered? And if you haven't recovered, then you have long COVID, and what do we do about that?
And the interesting thing in the community is that I don't believe we will probably get to that point, in that none of it's that clean, because there's secondary and tertiary conditions that muddy the waters around how much do you attribute to long COVID, to that symptomology or that symptom severity. And I think in the community, that's what we're finding is, they're either perimenopausal, menopausal. You're finding in hospital setting those correlations between burns and long COVID symptoms and recovery rates, and trying to look at solutions in those spaces. And we're seeing either clean cardiac, electric, neurological concerns or issues or outcomes, or this persistent fatigue, shortness of breath, and cognitive fog. And the commonalities between those three and inflammation, global inflammation, and diseases that co-contribute or that have global inflammation as part of that diagnostic profile, it makes it really difficult to pull it apart and be able to attribute, which I think is where the GPs that we've been working with are getting really quite good at reading those tea leaves and being efficient in. I've observed that over the last 12 months, there's been a real increase in the efficiencies on referral, the investigative process, that they're feeling more confident in how am I going to manage this case, because they've purely just had enough cases to develop a protocol for themselves. And it varies from a community point of view, from GP to GP, because there's no standardised.
I think part of the big issue is that inflammation affects the neurological system, and therefore it can affect the neurological system in any way. Essentially, the only system that actually links our whole body is the neurological system. So if you have damage or irritation or inflammation in your nerves and your neural tissue, then you can have any manner of symptoms. And that's evident in, long COVID has something like 200 symptoms, noted as long COVID symptoms, and that's because it can affect your brain, it can affect essentially any part of the neural system, as well as it can affect the end organs of the neural system. So it can affect skin, it can affect any of your organs if they're not functioning properly, because the neurological system isn't functioning properly. So
and I remember back early days, that's where the cardiologists and the respiratory physicians were like, no, it's a cardiological impact condition, no, it's a respiratory condition. There was that tug and push and pull between who should be referred as a specialist first from that diagnostic and process aspect. And then the cardiology is really interesting, because you've got the neurological aspects of that, but then you've also got the circulatory and vascular considerations. So, but that comes back to, again, is there a primary vascular issue? Is there pre-existing high blood pressure? Is there, what are the risk factors for that individual in that space?
I think if we go back to the very, very first phenomic profiling that came out, as far as I remember, from either Harvard or Stanford or one of those places, they demonstrated that it was actually the respiratory cells which were driving the inflammatory process with the early COVID. Now, whether that's different or not is another thing, but I think that essentially any epithelial cell could probably drive the COVID response, because even in this first wave, if you think about the symptoms that were more prevalent in the first wave of COVID, it still included some gut symptoms like diarrhea and gut aches.
Absorption issues.
Yeah. But then, when we got to Omicron, that was actually the primary symptom, or a more prevalent symptom than what we saw in the early days, which was much more a respiratory disease. So it's really, it's interesting just to see how the COVID organism has changed and how that's changed what parts of the body seem to be affected most, and why, who knows. Someone very clever will come up with that at some point, but it's just really interesting to see what's happened over time. But ultimately, I think what we're seeing is, or what we are beginning to understand, is that inflammation is, and the immune response to the inflammatory process is what drives the syndrome that comes after. And I don't think we've got enough understanding of why some people get certain symptoms or have certain problems compared to others. They're trying to find that. I know the Isaric guys over in Oxford in England have big data and they're looking at those things. I don't think they've got to the bottom of it yet as to why certain people die, certain people have cardiac problems, certain people have gut problems. It's still under investigation, essentially.
Yeah. And I think that's that awareness base and understanding that at a community level, which is where we're currently at in managing Australians presenting with these symptoms, is the consideration around the gut and the profiling around anxiety and depression. And it comes back to that monitor and measure space, which is, I think that's one of the positive things about long COVID, is that because of the lack of knowledge that everyone's had, it's forced us into the watch, monitor, measure, respond space.
Yeah.
And I think that, in line with ICHOM standardised sets that are starting to evolve into more of a value-based or common core of looking at the individual's mental health profile, their physical health profile, and then their pathospecific profiling, that's where it has, we've seen it probably evolve into that chronic disease management and triage space. And I suspect it will continue to evolve into that scenario, and hopefully the research that comes back is more in these higher level observations of, the immunoresponse and phenoresponse to indicators to burns, to long COVID, menopause, hormones, etc.